Well, good morning, everybody. As Maureen said, I'm Suzanne Baldivieso. I'm the nurse and clinical coordinator at the University of Maryland IBD program. And today I'm going to be talking about asking the right questions when you're triaging your IBD patient over the telephone. I have a lot of experience doing that. On an average day, I could get 35 incoming calls sitting in an office outside of our clinic. Patients who are calling to say either I have symptoms or I have questions about my medication and I don't know what to do. So today we're going to discuss, I have to, disclosures, AbbVie, sorry. We're going to discuss the who, what, where, when, and why by using some common scenarios. I have 4 case studies that we're going to review for some common symptoms that our patients call to ask about. I'm going to introduce a couple of useful tools that you can use when patients call, and it's helpful to understand what questions to ask and why, so that your patients can get the timely care that they need, the appropriate care. And especially with patients with Crohn's and UC, they can be a lot different than the average GI patient who calls to say, hey, I'm having diarrhea today. So that leads us to case study number 1. The cases we're going to review are going to be partial bowel obstruction, diarrhea, patients who are on immune modulators or anti-TNFs who call with infective symptoms, and patients who call with perianal symptoms. So case study number 1. Patient J is a 27-year-old male diagnosed with obstructing ileal Crohn's at age 19. And in 2012, he was hospitalized with a partial small bowel obstruction. And at that point, he was started on an anti-TNF and an immune modulator. He was noted to have inflammatory stricture on his colonoscopy, and he had the option of either a surgical intervention electively or medical therapy. So he decided in January, he decided to go with medical therapy, obviously. So in January of this year, he called to report worsening symptoms. He was having some abdominal pain, and he said, I think I might be in a flare. So we have a routine of when patients call with symptoms, there's certain questions that we ask them, and these are based on the modified Harvey-Bradshaw Index for Crohn's disease, if the patient has Crohn's. So the first question we ask is, how are you feeling overall? You feeling well, slightly below par, poor, very poor, or terrible? And I can tell you they usually never say I'm feeling well. That's not why they're calling. So he said he'd been feeling poorly. He'd been having a lack of energy, difficulty sleeping, and he said, I've been having a little nausea, but I'm not vomiting. So question number 2 is abdominal pain, and it can range from none to severe. And he said, well, I'm having some moderate abdominal pain. And so, we discuss the location of the pain, the onset. Is there anything that makes him feel better or worse? And he said, yeah, well, I kind of, in his own words, he said, my gut feels depleted and sore. And the pain had started about 3 days prior to the call. And he noticed that when he ate, it was a little bit worse afterwards. And he had, pain was generalized, but it was worse in the right lower quadrant. Excuse me. He said his abdomen feels a little distended and bloated. And then the third question we ask is, how many liquid stools are you having a day? And in his case, he wasn't having any. His baseline is like 1 form stool a day. And he said, the last time I went to the bathroom was 2 days ago. And I saw a little bit of bright red blood afterwards. So additional questions that we ask are you having any fever? And we tell our patients who start on immune suppressant therapy make sure you keep a thermometer on hand and monitor your temperature. Because sometimes they'll call and say, well, I think I might have had a fever, but I don't feel hot now. And did you check your temperature? So he said he had checked it and he didn't have any fever. Are you able to pass flatus? Because he hasn't had a bowel movement in a couple of days, which is abnormal for him. And he said yes. And so it's helpful to understand his history. When I pull up, we use Epic charting system. And when I pull up that patient's chart, I try to do a quick review of their history, their medications, so that I can ask them, are you taking your anti-TNF? When's the last time did you take it? And then another important question that's vital is we ask if they're able to tolerate oral fluids, because frequently they don't feel like eating much, but ability to tolerate fluids is key in helping to determine if a patient can be managed safely at home or if you need to send them to the emergency room for IV rehydration. So I asked, well, what have you been able to eat? And he said, well, I tried a little chicken soup, but he had nausea and increased pain after trying to eat. So in our practice, and this is in collaboration between the nurses and the physicians, we have emergency recommendations for our patients. We'll say, until I get a chance to the doctor, I want you to understand, in the meantime, if you develop a fever, intolerable pain, inability to tolerate oral fluids, or inability to pass flatus for more than 24 hours, then you need to go to the emergency room for emergency evaluation. So I talked with his provider, and he recommended what we call our partial SBO diet. They have go on 2 days of clear liquids, 2 days of full liquids, then 2 days of an ultra-low residual diet. And if their symptoms are improving, then they can advance their diet as tolerated. And typically, we give tramadol 50 to 100 milligrams every 6 hours as needed for pain, and then some Zofran for, or whatever antiemetic the patient tolerates and has used and works for nausea as needed. So Mr. J improved over the next few days, and he was scheduled for a colonoscopy, which showed a stricture, and he was able to be dilated. And then we took him back to clinic and did some testing. We checked drug levels, and dosing was optimized, and he remains in clinical remission at this time. So case study number 2 is Mrs. P. She's a 54-year-old lady with a history of UC. She's had a total proctocolectomy and a J-pouch procedure, and she has been experiencing recurrent bouts of pouchitis and cuffitis on and off for about 5 years. So January of this year, seems like a lot of things happened in January. Attempts were made to taper her budesonide, which she had been on long-term, and she frequently had issues with recurrent symptoms when we would drop her down to about 6 milligrams a day. So she had a pouchoscopy this year that revealed active pouchitis. So they decided to start her on IV therapy with vedolizumab, and she had not responded to multiple anti-TNFs. So she received the standard loading dose of that, and then her budesonide was tapered down further every 3 weeks until off. So she called to report the following symptoms. She had joint pain and swelling in both hands, which was severe enough that it was affecting her quality of life. She was having issues with like trying to hold a glass to take a drink of water because her hands were so painful. And then she developed 10 to 12 watery stools per 24 hours with urgency and nocturnal incontinence. And then the baseline numbers of stools were, when she was well, were about 5 per day. So we knew there was some sort of a problem going on. Now, the questions that we asked were based on the simple clinical colitis activity, which we continue to use for patients who have a history of UC but have had the J-pouch surgery. And So we ask about bowel frequency, and during the day she was having 7 to 9. We ask about nocturnal frequency. She was getting up 1 or 2 times a night. And she was having some issues with incontinence, which goes to urgency of defecation. How quickly do they have to get to the bathroom? She wasn't seeing any blood in her stool. And we also ask about the extraintestinal manifestations like mouth ulcers, any new lumps, bumps, or rashes on their skin, joint pain or swelling, which she was having joint pain and swelling. So we ask her as well, are you experiencing fever? Nope, no fever. Any sick contacts because she has diarrhea? And I mean, maybe she was exposed to, maybe one of her college student kids brought something home. But she said no, she hadn't been around anyone that was sick that she knew of. And have you had any antibiotics that were used to treat another illness? And she said, well, yeah, as a matter of fact, I had a sinus infection. About a week ago, I've been on antibiotics. And in our practice, we ask our patients to take a probiotic if they're not on daily probiotics, which especially a J-pouch patient might be. But she didn't happen to be at the time. And able to eat and drink like normal. Well, she's tolerating liquids, but she did notice a loss of appetite. So it's important to note the following when you review her history, is that she's had recurrent pouchitis and cuffitis, so you wonder if that's what's going on. She also had recent initiation of new medical therapy, so that probably hasn't had a chance to work yet. And then she was recently tapered off of steroids, and we know from her past history that she's had issues with this. So all of the other important questions were asked because that's going to help us determine what sort of additional diagnostic testing she might need, as well as potential treatment. So the provider recommended, he wanted her to drink oral rehydration solutions to avoid dehydration. I'm going to go over that a little bit later in the presentation. And then she was advised to start a probiotic and to continue that while she was on the antibiotics. And then we checked a C. diff PCR just to make sure, because we know that our patients with Crohn's and UC can be more prone to develop C. diff. Her C. diff PCR was positive. She was successfully treated with a 14-day course of antibiotics. And then she was able to stay off of the budesonide and start maintenance dosing of the vedolizumab. So she's healthy, she's doing well at the moment. And then our third case study is Mrs. S., a 30-year-old lady with a history of Crohn's disease. Earlier in 2016, she completed induction dosing of adalimumab and has been on maintenance dosing every 14 days for several months. As part of her medication education, she was advised to contact our office if there was any new onset of fever so that we could make recommendations, depending on what other symptoms she might have. And we tell them if you have a fever and you're on an anti-TNF and you inject at home, then you need to hold it and you need to give us a call. And if it's on the weekend, we want you to call the on-call service and let them know. And, we still don't want you to take that medication until you hear back from us. So in November of this year, she reported that she had gone to see her PCP. She was on her second course of antibiotics for a sinus infection, but she's still having issues with upper respiratory congestion, headaches, no fever, no chills, no cough, was due for her maintenance dose of anti-TNF in 2 days. And she said, do you think it's going to be okay for me to take it? And I said, well, keep an eye on your temperature, and if you stay afebrile, then yeah, it'll be okay. But if you develop a fever, we want you to hold it. She was due to inject on the weekend. So Monday morning, I get a phone call, and she said, I held my injection. I checked my temperature later that evening, and I had a fever of 101, and her temperature was up to 102 that morning, and we advised her, you need to go to the emergency room and be evaluated. and she had a 5-day hospitalization for treatment of severe sinus infection. Her tonsils were affected and abscessed, and so she had a course of IV antibiotics, went home on some oral antibiotics. Once she was afebrile for at least 72 hours, we told her she could go ahead and inject her anti-TNF. And once again, these are all recommendations that we've worked with our providers, and this is what they want their patients to do. So we already have that outlined, that that's how we're going to manage this patient. And she's now well and didn't experience any antibiotic-associated diarrhea because she took her probiotics, and she didn't have a flare of her Crohn's, even though she took her anti-TNF a little late. So our final case study is Mr. Z. He's a 36-year-old with a history of complex perianal Crohn's, and he's on infliximab infusions every 8 weeks. And he said, I've got this rash on my right buttock, and it's just been getting worse, and I think I have a full-blown abscess. So I asked him, is there any fever? No. Can you feel a lump? If you can feel a lump, where's it located? Is it swollen, tender, or painful? Is there anything draining from the area? He said, yeah, I have this nickel-sized lump in my right perianal region. He said, I used to have a ceton there. And, I was looking through his history. Spend a lot of time listening to your patient, because sometimes what they have to say to you isn't what you expect. And so you really need to take some time to focus on that. A lot of times I'll get a message from a patient. I've already looked at that history before I give them that call back, because I really want to focus on what they're trying to tell me when we talk. And asked him about what he was doing to alleviate the pain, and he had been through this before, so he started some sitz baths and took some acetaminophen, but it wasn't really doing too much for him. So he'd been on a tapering course of Cipro after his initial perianal fistula had resolved and the ceton was removed. And he had completed that Cipro a few weeks prior to calling with the symptoms. He was due for his regular dose of infliximab the following week. So after discussion with the provider, he was recommended to start Cipro twice a day, some tramadol for pain, because in our practice, we're very much against using narcotics in our IBD patients unless absolutely necessary. And then once again, he got our emergency recommendations as well. For intolerable pain, fever, he should go to the emergency room for evaluation. So he was seen in the office by the provider the next day. We try to leave a little space for what we call quick sick appointments for when something like that happens, and the patient really needs to be examined hands-on urgently. And that confirmed that he did have a perianal abscess. He was advised to continue the Cipro, tramadol, and sitz baths. And he was scheduled for exam under anesthesia and ceton placement. And then he got his infliximab dose after the drainage of the abscess and the ceton placement. So in summary, there's a number of common scenarios when an IBD patient calls to report symptoms. I've gone over what I feel like are 4 of the major ones that our patients call with. And working with your providers to develop a routine set of questions is very helpful, because then you sort of have a guideline to go by. And it's a relatively easy thing to do to develop and implement interventions that can avoid ED visits and hospitalizations. So once again, it's important to review your patient's history, take a look at their last office note, know what medications they're on, and ask them, have they been taking their medications routinely, or did something happen like a lapse in their insurance and they never called to tell anybody? And then you can utilize tools such as the CCFA IBD nurse triage form. And it's really interesting when I came to our practice, I had been a critical care nurse for 20 years in the hospital. So it was my first time on a telephone with a patient, trying to figure out what's wrong with them. I'm used to having a patient that might not be able to tell me what's wrong, but they're surrounded by every monitor. You know, we can monitor their heart rate, their bladder pressure, their temperature, and just by looking at a screen. And now we have a patient who just says, my stomach hurts. And it really was a challenge for me to try to figure out, and I worked with my provider on this, what type of questions I needed to ask. And he kept telling me, oh, you need to go to the CCFA website. You need to go to the CCFA website. So I actually got an email after I was asked to speak about telephone triage from a doctor at another practice, and he said, hey, our IBD nurse is going out on maternity leave, and we have these nurses who are going to fill in, but they don't know anything about IBD. He said, what's a routine set of questions that you ask your patients when they call to report symptoms? And I said, oh, have I got something for you? You need to go to the CCFA website and go up to the little link where it says Science and Professionals, click on that, and then just type in IBD triage form, IBD nurse triage form. And this two-page questionnaire pops up. And unfortunately, I wasn't able to put it into a slide. We worked on trying to do that. But I do have a link here at the bottom for ccfa.org, and it's pretty easy to find once you get on there. So this is just a sample of some of the kinds of questions that are on the nurse triage form. And there's, you know, it's really comprehensive. It's a great tool. I'd say especially if you don't see a lot of IBD in your practice, or you're new to GI or IBD, that you might find this really helpful, especially as you're first getting your feet wet. So this has the partial Harvey-Bradshaw index that we use for our Crohn's patients, the simple clinical colitis activity index that, once again, that helps to guide our questions. And if you're into scoring, you can do a little score at the bottom. And usually our patients that are calling to report symptoms, they may not be in remission. They may be having a flare. And then at our facility, one of our nutritionists had worked with our doctors to come up with Rehydration Solution recipes. So we have a list of recipes that most patients are able to get the ingredients for relatively easily, and they're strongly encouraged to drink these formulas. And there's things that are commercially available too, like drip drop solution that they can mix up at home, and that really does help to keep a lot of patients out of the hospital. And you know, if we're concerned about potential for dehydration, then we make sure that they understand the signs and symptoms of what they might feel if they're getting dehydrated. And I actually have a copy of that with me, as well as a copy of the CCFA tool. I can try to run off some copies a little bit later for anybody that's interested. You can just come and see me. Okay. And that's it for today's presentation on IBD triage.